días. Buenos días a todos y a todas. Bienvenidos nuevamente a una jornada más de la Diplomatura de Redes de la Universidad Jauretche, que cuenta con la colaboración y el apoyo del programa Sumar. Hoy es un día muy especial para todos nosotros porque por primera vez en la Argentina el equipo del Instituto de Métrica y Evaluación para la Salud de la Universidad de Washington, un instituto muy prestigioso que está haciendo grandes contribuciones a la mejora de la salud global, va a estar con nosotros contándonos toda su experiencia y como dice la presentación de la diapositiva inicial de la presentación, tener un panorama global, regional y también de la Argentina sobre la situación de carga de enfermedad actual. Así que bueno, mi rol en este primer paso del día es poder presentarles a Christopher Murray y a Cristian Baeza. Cristian Baeza ustedes lo conocen, ya es un profesor permanente de la Diplomatura de Redes. Así que comienzo con la presentación. Bueno, Cristian Baeza es médico, es director del Departamento de Soluciones Globales de Salud del Instituto de Métrica y Evaluación para la Salud. Ha sido director de la práctica global en salud, en nutrición y en población del Banco Mundial. También ha sido director de la División de Sistemas de Salud Globales en la firma McKinsey. Ha sido director del Fondo Nacional para la Salud en Chile. Bueno, y es profesor de la Universidad de Washington, de la Universidad de Hopkins y también de la Universidad Arturo Jauretche para esta diplomatura. Así que bienvenido, Cristian. Y también, bueno, un gran honor presentarles a Christopher Murray, que es el director del Instituto de Evaluación y Métrica en Salud de Washington. Él es médico, además es economista, ha dedicado toda su vida a la generación de metodologías para evaluar el impacto de la enfermedad en la salud, para medir la efectividad de las intervenciones, y es el fundador y el director del instituto, y además es uno de los creadores de la metodología de carga de enfermedad. Me gustaría agregar que es autor de cientos de publicaciones, de más de 200 publicaciones, de 14 libros especializados. Ha trabajado también en la División de Generación de Evidencia e Información de la Organización Mundial de la Salud. Ha sido también director de la Iniciativa de Salud Global de la Universidad de Harvard. Y tenemos el gran honor de que hoy nos acompañe y que nos cuente cuál es la situación actual de la carga de enfermedad en el mundo y particularmente en la Argentina. Tendremos la primicia de poder conocer los datos actualizados al año 2013, que todavía no ha sido difundido, y nosotros hoy, todos nosotros tendremos la primicia de conocer, bueno, cómo está el mundo y cómo está particularmente nuestro país, cuáles son los principales problemas de salud a los cuales nos estamos enfrentando hoy y a los cuales nos enfrentaremos en el futuro cercano. Así que bueno, dicho esto, pido un fuerte aplauso para darle la bienvenida a Cristian y a Christopher. E invito a mi querido amigo Cristian Baeza a que comparte algunas palabras de inicio también con todos nosotros. Maestro.
Muy buenos días, muchas gracias por la invitación. Para mí siempre es un enorme placer estar en la Argentina, estar en un evento organizado por el Plan Sumar, Nacer, y estar ahora de profesor honorífico de la Universidad Jauretche. Muchas gracias por la invitación. Para mí además es un placer particular porque hoy día yo cumplo mi 20º aniversario de haber comenzado a trabajar en Argentina. No me había olvidado a mí. Fue en octubre en realidad del año 95 que yo tuve la oportunidad de venir a mi primera misión, así se le llama en las multilaterales, a la Argentina. Así que es un gran placer. Nuestra presencia hoy día responde o se inscribe en una colaboración que hemos establecido entre el Ministerio de Salud, el Plan Sumar y la Universidad de Washington, específicamente el Instituto de Métrica y Evaluación que dirige Chris Murray. Y para nosotros la colaboración en el marco de la Argentina haber tomado la decisión de poner al día su carga de enfermedad, pero aún más en el marco de que nos hayan invitado a ser partners, colaboradores en un esfuerzo que el instituto está haciendo, que es el esfuerzo de movernos también desde el cálculo de la carga de enfermedad ahora a las proyecciones de la carga de enfermedad y rápidamente a cuáles son las implicancias de esas proyecciones para los sistemas de salud. Así que estamos muy agradecidos. Argentina es el primer país con que estamos trabajando en el tema de forecasting, como diríamos en inglés, y si nos permiten también felicitarlos por tener la visión de estar trabajando en este tema, que es un tema muy señero. No me sorprende Plan Sumar y Plan Nacer, que es más conocido para mí, siempre ha tenido la visión, y Martín en particular, de moverse los temas que son frontera. Hoy día tenemos y digo tenemos porque me siento también privilegiado de tener la oportunidad de tener a Chris Murray presentando carga de enfermedad. Como ustedes saben, como Martín dijo, Chris es el padre y madre de los DALYs y la carga de enfermedad. Lo puedo decir porque yo soy relativamente nuevo como profesor de la Universidad de Washington, pero he seguido la evolución de la carga de enfermedad desde las múltiples encarnaciones laborales que yo he tenido, como mencionó Martín. Y me parece a mí, por lo menos desde afuera inicialmente y ahora trabajando conjuntamente con Chris, que el tema de la carga de enfermedad, el desarrollo de la carga de enfermedad, es para mí una de las historias más inspiradoras de salud global que yo he visto. ¿Quién habría creído que nosotros que el mundo se iba a entusiasmar con esta motivación de la epidemiología? Cuando yo estudié epidemiología hace 25 años atrás, la epidemiología era algo difícil, numérico, difícil de conectar con la realidad de las políticas. Y me parece que una de las virtudes de la carga de enfermedad, y particularmente una de las virtudes de cómo se comunica la carga de enfermedad hoy día, las visualizaciones que los equipos han hecho, han permitido hacer un puente entre la evidencia epidemiológica al nivel que carga de enfermedad permite estudiarla, y la comunicación con hacedores de política, que normalmente, habiendo sido uno de ellos en el pasado, uno tiene más o menos una atención de 5 minutos, o 10 en el mejor de los casos, y esta comunicación es muy efectiva. ¿Por qué me parece tan importante? Y Martín me pidió conversar un poquito de cuáles son las implicancias, ¿no? A mí me parece, habiendo visto el tema de carga de enfermedad por tantos años, que hay 3 razones críticas por las cuales el tema de carga de enfermedad, a mi juicio, ha cambiado la forma en que utilizamos la evidencia para política. Una es que es imposible hacer políticas de salud si uno no conoce la salud de sus poblaciones. Y por muchos años habíamos tenido una forma de mirar las prioridades de salud casi en compartamentos estancos, ¿no? Yo soy neurólogo de formación. Si hace 20 años me hubieran preguntado cuál es la prioridad en salud, muy probablemente muchas de las patologías neurológicas habrían estado en el top de mis prioridades. Si uno le preguntaba a un pediatra, habría pasado lo mismo. Si le hubiera preguntado a un cardiólogo, lo mismo, ¿no? Y por primera vez tenemos una herramienta que nos permite mirar en conjunto todo el problema de salud de la población y nos da una métrica acordada que nos permite decir, sí, efectivamente en este país esta área de morbilidad y de mortalidad es una prioridad y esta otra es importante, pero era menos de lo que pensábamos. Esa es la primera. A mí me parece muy importante. A mí me tocó colaborar con la creación de un plan en el otro lado de la cordillera, se habrán dado cuenta de dónde vengo por mi acento, en Chile, que se llama el Plan Auge. Y yo recuerdo las conversaciones iniciales de crear el Plan de Auge, que es un plan de garantías de salud para la población chilena. Y una de las puntales de esa discusión fue, bueno, pero ¿dónde están las prioridades? Y la carga de enfermedad nos permitió por primera vez tener una conversación que era basada en evidencia y no solo en impresiones de especialistas. Hay una segunda razón por la cual yo creo que es súper crítico el cambio que ha traído la carga de enfermedad a nuestros países, que es que nos permite planificar hacia futuro. Nos permite mirar el tema de cuáles son nuestras prioridades sanitarias y ver, y ahora más con el tema de forecasting, ver hacia dónde van y cómo se encuadra lo que estamos haciendo hoy día en planificación sanitaria, en inversiones, en recursos humanos, etcétera, con lo que deberíamos estar haciendo mañana. A mí me tocó tener una conversación con el ministro de Salud de Turquía hace un par de años atrás, algunos de nosotros estuvimos en esa conversación, y el ministro de Salud de Turquía con mucho entusiasmo estaba muy feliz de lo que Turquía había hecho en los últimos 10, 15 años, que era un tremendo esfuerzo sobre salud materno-infantil, una reducción muy importante de mortalidad infantil. Cuando hicimos el análisis de carga de enfermedad con ellos y las implicancias, nos dimos cuenta, bueno, dijimos, mire, bienvenidos al futuro. Felicitaciones por su reducción tremenda de... Gracias. Su reducción enorme de carga de enfermedad materno-infantil. Si uno la mira hoy día, ustedes tienen un tsunami de enfermedades crónicas no comunicables. Y cuando uno mira la estructura de su ministerio, tenemos 1000 especialistas en el tema de salud materno-infantil y tenemos 7 en el tema de carga de enfermedad. Hay un tema de transformación que nos permite mirar ahora con mucho más detalle, ¿no? Imagínense lo que significa transformar a un ministerio que está fundamentalmente concentrado en materno-infantil y que tiene que moverse hacia carga de enfermedad. Hay una tercera dimensión que es la que a mí más me entusiasma, porque alguna vez fui político, hice mucha política y creo que no me he separado de ella, y con esto termino, que es la dimensión de que yo pienso que la carga de enfermedad le da voz a los que no tienen voz en salud global. Por muchos años, yo he trabajado mucho en salud global, la asignación de recursos en salud global tenía más que ver con tu capacidad de argumentar que tu tema era un tema prioritario para la salud mundial, más que con si efectivamente era el tema prioritario desde el punto de vista de la evidencia. Y por primera vez, a partir de la carga de enfermedad, yo diría particularmente a partir del esfuerzo de carga de enfermedad de mediados de los 2000, tenemos una forma de mirar cuáles son las prioridades, tengan o no tengan los sujetos de esas prioridades voz y una silla en la mesa de la conversación global. Y yo creo que, por ejemplo, el enorme rescate de la salud materno-infantil y la creación, por ejemplo, de la plataforma de materno-infantil del Banco Mundial recientemente y otras, estuvieron tremendamente influidas por traer a la mesa una conversación de evidencia que sostenía puntos de vista de quienes no normalmente tenían o tienen una voz o una silla en la discusión de asignación. Sí, yo creo que tenemos un enorme privilegio de tener a Chris aquí. No es que Chris vaya a muchos lugares, tiene su agenda tremendamente ocupada. Pero que el privilegio es aún más. Ayer me tocó, y con esto cierro, tener una reunión con el equipo del Plan Sumar. Y para serles honesto, yo creo que deben haber habido 25 personas en esa sala. Y en esa sala estábamos conversando un tema de metodología que yo he visto pocas veces grupos nacionales con tanto entusiasmo, motivación y conocimiento de estar concentrados y enganchados en la conversación. Y me parece que eso es una tremenda virtud de lo que ustedes están haciendo y una enorme virtud de lo que el Plan Sumar está haciendo, de crear una masa crítica, de facilitar la conversación de temas complejos metodológicos que son ni más ni menos que el futuro de nuestra conversación en salud global, desde una conversación que va desde la motivación de siempre, por los valores de siempre, a utilizar los instrumentos de hoy y los instrumentos de futuro. Así que muchas gracias, felicitaciones por lo que están haciendo y muchas gracias por la invitación. Y ahora sí les doy el plato fuerte, que es Chris Murray. Muchas gracias.
Well, thank you, Martin and Christian, for the introductions and the context. And I think we're going to spend the next while going through both a sort of broad view of the global burden of disease a deeper dive into methods than I often do in this sort of context to help you understand where does this information come from, and then a look at both the global and Argentina type findings. A couple of framing comments about the Institute so that you can understand who we are and what is the role of the Institute for Health Metrics and Evaluation in this burden of disease work. We're an independent institute, about 230 faculty and fellows. And the notion behind the Institute that started in 2007 is that there's value in a science-based approach to understanding health and what health systems are doing. And I think what we do is focused on 6 areas now. The one that we're going to spend all the time this morning talking about is the very detailed analysis of health, which we call the global burden of disease. But at the very end, I'll talk about the next 2, which are the sort of new directions for this work, bringing the measurement down to a very fine-grained level, which can go under the notion around mapping. The most advanced part of that is for malaria, but we plan over the next few years to do that 1 kilometer by 1 kilometer level measurement for a host of diseases, including tuberculosis, HIV, pneumonia, diarrhea, and then potentially some other infectious diseases as well. The third area, which is the one we're very excited to be working with Plan Sumar on, which is the next generation of health forecasting. But some of the other areas that IHME has done, and I think are useful because you'll see that all of what we produce is a public good and is made available. We track money flows for health. We have a broad evaluations program. For example, we're the independent evaluator of the Global Alliance for Vaccines and Immunizations, Gavi. And as you may know, with Christian joining us, we're expanding our work on health systems and helping countries use these analytics to improve health systems. One thing, and I'll be showing you examples of this, is that we put a lot of effort into making information available to the public through online dynamic data visualizations. And that'll be most of what I will be showing during the course of this morning. But I do want to also say that we've put a tremendous amount of effort into making the underlying data that goes into our analyses available to academics, to analysts, and to anybody who wants to have access through something called the Global Health Data Exchange, which is the world's largest online catalog of health data. And essentially any source, whether published or direct from governments, that we use for the burden of disease and for our other analyses is now in the Global Health Data Exchange. And you can get at least the metadata about that source. So if you want to know what's being done on musculoskeletal disease in Argentina, you can search for that and find it. So it's a tremendous resource for others who want to do further analyses of the primary data. And then I will be showing, and Peter Speer in the afternoon will be showing also this host of online dynamic data visualizations that we've now produced as ways to explore highly complex data that we access, analyze, and curate. And so a number of illustrations of that will come up in the course of the morning and the afternoon. All right, so that's a little bit of context around who we are. On to the main components of this morning, where I want to tell you about the organization of the burden of disease, a deep dive into some of the methods. We run a 2-week training course, and I'm not going to condense into the 2-week training course into a few hours, but I'll give you a flavor of what goes into the burden, because if you don't know that, then you won't necessarily have much confidence in the findings that I'll be showing you. And I think it raises some interesting Argentina-specific issues on the methods that may be useful in thinking about the future of health information here. and then go through the results globally and then the results for Argentina, and then comment on where we're going next. Okay, so what is the burden of disease? Well, the burden of disease started almost 25 years ago. We first started work on it in 1991, so we're on 24 years now. It was initially launched by the World Bank, not the World Health Organization, but eventually WHO became a key part of it. And the idea was that if you wanted to have an informed discussion about health policy, you needed to have a broad view of what people's health problems were. And starting from very modest beginnings, where essentially Alan Lopez and I largely, with the help of a team of very young analysts, put together all the data in the early 90s and looked globally and regionally at findings, which now evolved into a rather sophisticated measurement approach that tries to capture all the world's data for all countries greater than 50,000, so that's 188 countries. It's not just a single snapshot, it's a time series, and so we're always producing a consistent time series from 1990 to present. It covers an exhaustive list of diseases and injuries. So every disease and injury shows up either on its own or in some aggregate category. So across the entire spectrum of diseases and injuries, we cover these 306 categories. For a given disease, we often track multiple outcomes, or what we call sequelae. So for example, for diabetes, we look at diabetes itself, we look at diabetic retinopathy, diabetic neuropathy, chronic kidney disease related to diabetes, etc. And so if you add up all the different clinical outcomes that we track, we actually are tracking over 2,000. And in addition, the burden of disease looks at some of the key behavioral, occupational, environmental, and metabolic risks. And currently that list is covers 79 risks or combinations of risks. Big evolution around the burden of disease. This used to be a gargantuan effort that took 5 years in each cycle or more. And now we've actually shifted into producing annual assessments. And this cycle and then next year will be the first time it's actually a 1-year gap between them. And I think by becoming annual, it is a more reliable global public good that can be used for monitoring and planning purposes. And our plan is to release each year's update in May. And so the first of those May releases we are foreseeing next May for GBD 2015. We'll be talking about the results for GBD 2013. The number at the end of the GBD refers to the last year of the time series that's estimated. So GBD 2013 means 1990 to 2013. Next year we'll jump 2 years and we'll be estimating from 1990 all the way through to the end of 2015. We have a dual strategy, or a triple strategy, I should say, of release of information. To maintain the highest possible scientific standards, we publish methods changes and key findings in leading journals, ranging from Science, New England Journal, Lancet, JAMA, etc. And release all the data online through data visualizations. And depending on requests and funding, various governments have asked for specific policy reports or various multilateral organizations, the World Bank, Commonwealth Health Ministers, and others. So that threefold dissemination strategy. Now, when you talk about the burden of disease, a first question you usually get from any audience is, well, where's the data that is going into the burden of disease coming from? And so I want to start in a very high-level sense of where do we get the data that we use. So we try to capture all the government sources that exist, vital statistics, household surveys, censuses, and administrative data. And depending on how closely we're working with governments, that may be very detailed that we access and use in the case of the Chinese government or the UK government, or it's what's publicly available or released through websites or annual reports or other types of sources. Second, we systematically review the entire published literature on epidemiology. So for every disease and injury in the GBD, we have searched the published literature and tried to extract any study that talks about incidence or prevalence or death from a disease or injury or a risk factor. In addition to these sources, there are a number of multinational efforts around data collection that, like the World Bank or UNICEF, or the USAID fund, like the Demographic and Health Surveys, the Multiple Indicator Cluster Surveys, the Living Standards Measurement Surveys, and we systematically capture what's publicly available, in many cases negotiate access to things that aren't yet publicly available. And as I've mentioned, everything we use goes into the Global Health Data Exchange so that you can understand where, for Argentina or whatever country you're interested in, what are the actual data sources. Now, you might ask, what's unique about the GBD? And I think it's useful to think about the GBD in terms of the short list of classic problems that we have in thinking about health data and how the GBD effort provides a solution to those problems. So on the left on this slide are 4 major issues that I'm sure anybody who's ever worked with health data have come across. Inconsistent coding and case definitions over time or across community or within a country. No data available for a particular outcome in a country. Studies that are more than one study is available, but they give very different answers. Frequent problem, and the one that I think people don't remember is actually quite a chronic problem. And then the general problems of different types of measurement error. We know that even if you've run a good survey or you have vital registration, there's all sorts of various types of measurement error that's out there. And the GBD provides a standardized framework for dealing with these problems. It's not perfect. There's a vast array of data that goes into the GBD and a vast array of outcomes. But compared to anything else that's been produced in the past, there's been a much more standardized, rigorous, systematic approach to these issues. So we quality review all sources. And as we will dive into, we correct for the chronic problem of what's called, at least in our area, garbage coding, where causes of disease or death get assigned to causes, to codes or causes that are impossible or inappropriate. And that varies by medical culture or medical legal issues. So in some countries, Chile is a good example, there are reasons, medical legal reasons, where physicians aren't willing to put on death certificates the cause of an injury. And so you have a tremendous problem with ill-defined injuries, as an example. Second, we standardize all the measurement to one case definition and one diagnostic technology. So, for example, we do what's called crosswalking in our language. Namely, if there are surveys of diabetes, some using different case definitions. For example, there's more than 20 that are in use across different countries that we have found. We map them all to one common case definition and do that mapping statistically. Now, that's imperfect, because unless we had the underlying raw primary data for every single survey in the world, we couldn't we could do a better job, but we have found ways to do this crosswalking statistically and try to capture the uncertainty in those measurements. And then we've come up with very standardized Bayesian statistical methods to deal with missing data, sampling, and non-sampling measurement error. So that's sort of why the GBD provides a unique framework for comparison over time and across place. The other thing that's unique about the global burden of disease is this is a truly global undertaking. So for the current cycle of the global burden of disease, we have 1,300 plus collaborators that are living in 114 countries. What that means is that there are people with local knowledge for the vast majority of countries, all the ones shown in green, that are contributing to the identification of data sources, to understanding of bias or error in national data sources, and critically in the interpretation of the findings. And so we view this network of collaborators as one of the most important advantages of the GBD approach. And you can see there's still patches in terms of the number of countries that we've engaged, but we're certainly making substantial progress in expanding the scope of who's participating in this effort. Now, the other thing about the GBD is that it's not just this effort to find all the data and standardize it. We have, in addition, computed a number of other summary measures that help us look at the big picture around disease and injury. So we have traditional metrics: disease and injury prevalence and incidence, death rates, death numbers by cause, age standardized rates, all the sort of things that you would expect from an epidemiological perspective. But in addition, we've computed various summary measures. For premature mortality, we compute years of life lost, which is simply multiplying deaths by the life expectancy in this standard that we use at the age of death. The standard we use is life expectancy at birth of 86. That's the highest observed life expectancy in the world. Then for disability, we take the prevalence of all the conditions in the GBD. We survey the general public in random sample surveys of the general public, and use the public's opinion about severity to weight prevalence on a 0 to 1 scale. And then we basically take prevalence times severity and sum it all up, and that's years lived with disability. So, and I'm not in this presentation going to dive deeply into this issue about why do we ask the public, how much cultural variation there are in these severity weights. They're all interesting topics, but it's its own separate discussion. The key finding there empirically is that there isn't that much variation in the data that's being collected about these severity weights across countries. There's quite a common sense of quadriplegia is a very bad thing, an episode of diarrhea is not so bad. And more formally, there's a reasonable scale that we're able to derive. And then DALYs, which is our apex measure in this system, is simply the sum of years of life lost with years lived with disability. The simple arithmetic sum. Now here's a visual of that of that notion of, or a cartoon of DALYs. Imagine an individual that we're following. And the y-axis here is the disability weight scale, where 1 is full health and 0, it's the reverse of the disability weight scale, where at the top here is in full health, down here is like death. And this individual has a period of disability, goes back to full health, develops some disability, and then dies. The years of life lost part is the red part in this cartoon. The years lived with disability part is the blue part, and we put those together in this metric of DALYs. We also compute something called healthy life expectancy, which is the reverse, which is the green area, aggregated up at the population level. All right, so that's just some framing. Here is a super simplified schematic of what we do in the burden of disease. And we have been putting more and more effort into trying to make more and more detailed schema, so that if you're interested in a particular outcome, you can actually trace exactly what's going on. But you can think of the burden of disease work largely in 4 big blocks of analysis. The analysis up here on the top left of death rates by age and by sex. The analysis in these green boxes of causes of death. The analysis in purple of disease incidence and prevalence. And then the analysis here in these blue boxes of risk factor prevalence, risk factor relative risks, and then putting it all together in terms of attributable mortality or disability. The yellow box is the 5th area, which is really going out and measuring disability weights. But that's a sort of standalone set of studies that have now been done in about 10 countries, and we use the pooled data globally for the GBD. Okay, now we can drill down and go through each of these blocks in more detail, and when we run a 2-week training course, as some of the participants from Argentina know, there's a big plasticized version of this that helps guide the training materials, because we literally go through each of these components. And even then, I'd say after 2 weeks, that's a relatively light touch to give you the sort of big picture view. And so I'm not going to go through every box here. What I want to do is show you just a few highlights around methods in a moment. But first, I want to talk a little bit more about some of the policy use that's emerged around the burden of disease, as to give a flavor of why we've gone in certain directions. So I'd say there was a quantum leap in the global burden of disease methods and sophistication when we went from the burden of disease results for around about the year 2000, and there was a series of years where WHO put out burden of disease results when I was there, and Alan Lopez as well, from 99, 2000, right through to 2003. And then it took that sort of didn't get updated. And then for the GBD for 2010, which was published in 2012, there was just a dramatic advancement in the methods used, with particularly the sophistication around the statistical analysis going up really quite dramatically. With the publication of GBD 2010, which was the first analysis country by country, what we hadn't anticipated was the value that some governments put on the burden of disease results as a tool for benchmarking. And so the day the results were released in December of 2012, the UK government asked if we would help them use the GBD database to answer their Minister of Health's question, which was, how well was the UK doing compared to Western Europe? And in a very short period of time, really 3 months, this analysis was done jointly by the GBD team and Public Health England and published in The Lancet. And the high-level result was that despite expanding expenditure in the UK was still lagging behind quite substantially most of Western Europe, including places that spent quite a bit less money on health. And that certainly was not what they wanted to hear, but it was something that I think has now led the UK government and Public Health England in particular to say, well, what aspects around behavioral and metabolic risks and what aspects around some of the diseases where they were not doing very well should they be focused on to try to catch up with their peers. Same thing happened in China. We had a very interesting initiative from the Chinese to use the results to benchmark China against the G20. And although China is doing rather well, they identified a series of challenges that they saw coming, particularly the shift to non-communicable diseases, particularly some risks like tobacco and blood pressure. And this triggered in China a very active collaboration. We have 3 different teams from the Chinese government in Seattle right now, and this is their 3rd or 4th visit. And this year they've moved on to doing, as the UK has as well, doing subnational assessments at the province level, and even some for maternal and child health at the county level in China. So this is a sort of growing body of work to help both internal benchmarking and external benchmarking for China. And then the last of these examples was an event that we had at the White House in the US, where they saw the results of the burden of disease. Michelle Obama, the First Lady, has been a major proponent of reductions of obesity and increases in physical activity as her main theme. And so she asked, or her team did, if they could use the burden of disease and do some national work in the US to figure out who, if anybody, was doing a good job at tackling obesity, physical activity, and other risks. We then produced an analysis for JAMA, the Journal of the American Medical Association, and a policy report for the White House about both the national burden of disease and then subnational assessments, and launched this at the White House, and the White House brought in local decision makers from about 300 jurisdictions. So very nice bringing together of the analysis, but also using it as a proponent for policy change. And that's led to a series of follow-up activities with the U.S. government. Okay, that was just sort of a broad overview on the burden. And now what I'd like to do is go back a little bit and go through some of the methods aspects that I think warrant a little bit more attention. So the first step, the top left of that schematic, was mortality. And I am now going to shift over to one of our live tools. So this is online. If you want to find this yourself, you just look for healthdata.org in our data visualization page. And this particular data visualization is to help the analyst or the methodologist understand all the steps that go into the first task in burden of disease, which is getting age-specific death rates right. Now, you might say, well, isn't that a pretty straightforward thing to do? All you need to know is a census count, and you then need to know whether, a vital registration system, and you just add up the number of deaths and divide by the population. And the answer is not quite, because censuses sometimes have variable coverage. Some people's vital registration system, many in the middle-income world, don't capture all deaths. And in many low-income countries, there's no vital registration, and it becomes quite an analytic challenge to figure out just what death rates are. And there's a host of other problems that become stronger and stronger as populations age, to do with misreporting of age in the older populations, both in the census and death certificates. And age misreporting turns out to actually have some rather systematic biases. And that latter one remains a challenge even in the highest income countries. So in the schematic, we start with measuring child mortality. In this tool, you can pick any country that you want. I've picked Argentina. Here is, for each year, in purple is the under 5 death rate on a 0-1 scale. So this is, up here, 28 in 1990 per 1,000, under 5 death rate. And that's the actual data coming from the vital registration system in Argentina. And this is what was published at the beginning of this year. And the 2015 update will obviously add a couple more years of data to this. Now, what happens in the analysis, it's pretty easy for Argentina because our evaluations, which I'll show you in a moment, we believe the vital registration system in Argentina is complete. So that's a blessing. I mean, it's a tremendous asset for a country to have complete vital registration. In contrast, a country like Mexico does not have complete registration for children. They're still missing 15 or 20% of child deaths. And so then you have to go through this process of trying to figure out how to correct for that undercount. And that correction is usually made where there's household surveys used to adjust up the death count. We don't need to do that here in Argentina. And so there's the actual data. Here's the trend line for the first 6 days, the next 3 weeks, 28 to 364, and then ages 1 to 4. And I think of note, since we are here hosted by Plan Sumar and Plan Nacer, is that there was a period just before Plan Nacer started where mortality was actually going up slightly for children. And then since 2003, we've had a pretty rapid decline in 4 years, and then quite a bit slower decline since then. Now, before we celebrate too much, we'll have some more Argentine-specific results. Great result, stopping the stagnation. But when you start to put things in a global context, I think it gets interesting. For example, a country like China has been able to reduce child mortality at 8% per year over the last 10 years. Just extraordinary rates of decline. Progress can in some contexts be very fast. So that's the data that goes into the GBD for Argentina. Here's the under 5 death rate in 2013 on a map, and of course, as you know, there's still tremendous variation. And in Latin America, Bolivia would be the outlier here, along with Haiti in the Caribbean, as having much higher rates than other countries in the region. Now, I said we evaluate completeness. And so we don't just take people's word for it. There's actually formal demographic methods for the assessment of completeness. These are called death distribution methods. As part of the GBD research agenda over the last 20 years, we have improved, and by we I mean the collaboration of investigators, these methods, and have better variations of death distribution methods. The results are shown here. These are these little numbers that show our estimated completeness for the vital registration system. And yet the bottom line is that these formal assessments say that 99% of deaths are captured by the vital registration system here in Argentina, and we just assume that that's the same as 100%. Now, for adults, we tend to look at the primary data in one summary measure, which is 45Q15. This is behind the scenes. All the results for the GBD are age-specific, but we look like we do at child mortality with this one measure. We look at adults using the probability of death between 15 and 60. On the left side is the vital registration data, which again we've said is complete for women. So 10 per thousand is not that bad, and we've seen over the last almost 25 years a modest 15% decline in adult female mortality. And for men, back in 1990, the difference between men and women was almost double. And we've seen a decline down of about over 20% for men in adult mortality, around about 150 per thousand. Now for context, adult mortality in a place like Japan or Australia goes down to around 60 per thousand in this age group. So there's a big gap for males, and you'll see that as a theme later for adult male mortality in Argentina compared to the best in the world. Now, so that's where the data and the analysis. Now, this analysis is much more complicated for a low-income country because they don't have the complete vital registration. Finally, and I want to make sure I get the right view, you can look for any age groups. I'm here for Argentina. I am simply showing, and I'm going to zoom up, make that bigger to see.